Welcome everyone to our first webinar, PTSD, COVID-19 and its impact on mental health, organized by John and Josh Memorial Fund. My name is Hattie and I'm helping Braden, who is our moderator today for this wonderful webinar. I'm going to pass the floor to Braden. Braden, the floor is yours.
Hey, my name is Braden. I'm a PhD student under Dr. Ruth Lanius, who unfortunately can't be here with us today. But I was the lucky recipient for the past 2 years of the Jonathan and Joshua Memorial Graduate Scholarship that's offered in the Schulich School of Medicine and Dentistry. So I do research primarily on PTSD. Specifically, we look at different neural correlates associated with PTSD. And I have, as panelists, 2 co-authors that I've worked with quite closely that know the subject matter a little bit more in depth than me. And that's Dr. Andrew Nicholson as well as Dr. Margaret Mckinnon. So I'll now turn to Andrew, if he wants to just give a quick brief overview of what he wants to talk about, and then we'll get into the presentations. Thank you.
Thanks, Braden. Hello, everyone. My name is Andrew Nicholson. I'm an assistant professor in the Department of Psychiatry and Behavioral Neurosciences at McMaster University. And I've been collaborating with this group who includes Braden Turpot and Dr. Margaret Mckinnon, as well as Ruth Lanius. So at the sites of Western University and McMaster University, very in-depth over the last years. And what our research really focuses on is both understanding the underlying neurobiology of post-traumatic stress and trauma, and how we can actually mediate that, normalize this with novel adjunctive treatments. And that is what primarily I will be talking about today. And then Margaret, if you'd like to introduce yourself as well, then we can begin the webinar.
Sure. Thanks, Andrew. Hi, I'm Margaret Mckinnon. I'm an associate professor in the Department of Psychiatry at McMaster University, and I'm trained as a clinical psychologist. And I'm going to talk today about coping with COVID-19 related stress and some of the impact that the stress associated with the pandemic might have on us as individuals, as well as on people who have suffered trauma in the past. So what I'd like to do today is just spend some time from a more clinical perspective, talking about how we might cope during the COVID-19 pandemic. I'm also going to talk about some research work that we've been doing in our lab. And a lot of that work has been funded through the Jonathan and Joshua Foundation. And we saw some really nice results from Andrew showing how the work of the foundation has really transformed the treatment options that are available for PTSD. And I want to talk to you a little bit more about those treatment options, but also give you some practical tips around coping with COVID-19. So Brady, maybe we'll advance to the next slide if that's all right. So I'm Margaret Mckinnon, as I mentioned. I'm an associate professor at McMaster University. I'm also hold the Homewood Chair in Mental Health and Trauma, which is again the result of philanthropy. So it's actually a position at McMaster that is funded in part through donations to the university, and I'm very grateful to for that. Andrew, we'll go to the next slide, or rather, Braden. I just want to say that I may say things in this presentation that are not necessarily the view of McMaster University or any of its affiliates. These are really my own personal opinions, and I think it's important just to say that from the outset. So I want to start by, can you go back one slide, Braden? Thanks. So I want to start by thinking about how we overall think about COVID-19. And one thing that we know for sure is that this is a very unprecedented situation. None of us have found ourselves in this situation before, and it's causing unique challenges. Certainly it's causing also, I think, areas that actually have improved, perhaps, that we may have a greater appreciation of our friends and of our family during this time, but it's also unprecedented. And people, I think, have a sense that they've lost control in many ways with things happening in their lives. We also know that no one can fully prepare for a pandemic. So while we've seen, for example, in Canada, shortages of, in some cases, of personal protective equipment at the very beginning of the pandemic, we also know that everyone, is well-intentioned and we're trying to do our best. Everyone around us and many of our leaders as well are really trying to do their best, and it is very difficult to prepare for this. We also know that COVID-19 is a marathon, it's not a sprint. I can recall at the time that we were first told to stay at home, thinking this will be a couple of weeks, and that really would have been a sprint. But I think what we're seeing now is we're in this for the long haul. And we really do need to support one another through it. And just as I said, we're all in this together and we're learning about this together. We also know in many cases of situations that are happening around COVID-19, there really are no right or wrong answers. We're just working through this together to figure out how to handle very difficult and challenging situations. And as I said earlier, everyone here is really trying their best with the best of intentions for the most part. Can you go to the next slide, Brayden? So often, as Andrew had said, when we think about PTSD, really the concept originated from military members, so from soldiers in World War II, and they came home with what was called at that time shell shock. So some of them were very numbed out. They weren't present in the world around them, and that's really what Andrew showed earlier on when he showed the picture of the soldier who looked quite numbed out. Others were very hyper aroused. So they came back, they were very irritable, they startled easily, they were flashing back to their experiences in World War II in a way that they couldn't control. And that often caused a great deal of anxiety and distress for those individuals. As we moved forward, we began to think about PTSD in terms of other things that might happen to individuals who are not soldiers or military members or veterans. And that included things like car accidents, which I would expect many of us in the audience today have experienced. And so we know that being in an accident, for example, is a form of trauma that can cause symptoms of PTSD. I'm going to show you a slide in a few minutes that also indicates that many of us have experienced trauma during our childhood. So that may be sexual abuse, that may be physical abuse, it may be neglect. And what we know is that those numbers are probably quite a bit higher among the general population than we might think on the surface about who's experienced trauma or neglect during their childhood. When the COVID-19 pandemic first emerged, there really was a lot of discussion about how this was a very stressful event for Canadians. Life really shifted during the pandemic. It seemed like overnight, many of our expectations of ourselves and others, our roles at work, our roles within the family and our neighborhood and our community shifted in almost an instantaneous way. What I found, I do some administration as well, and I found that I would make a decision or I would send out an email, and within moments, the information would change. And I'd have to write a new email or make a new decision because things were constantly shifting. The ground was constantly shifting under our feet. And even now, we really do have an uncertainty about how long this will last. There's almost a feeling that there's a timelessness to this where we don't really know where the end point will be and what will bring us to that point. And these are certainly situations that are associated with a great deal of stress for individuals, for workers, for first responders, healthcare workers, and for families, particularly those with children who have been home during this time and who are now going back to school, many of them. So one thing that I would observe here is that many things right now are quite unpredictable. And if we think about the effects of COVID-19, this is really very similar to what people might have experienced if they had early life trauma or early life adversity. So for children, for example, who experience physical abuse or neglect, they really didn't have a lot of control over their bodies or over themselves. And COVID-19 can be very triggering for those individuals because it reminds them of those conditions that they might have experienced during childhood. So we're very mindful of that in the clinical work that we do around COVID-19, that it's not just what's happening in the present moment, but also what's happened in the past. And we talk here about the 90-10 moment, or 90-10 rule rather, that for most people, what they're experiencing, their emotions, their feelings, 10% of that relates to what's happening in the present moment, and approximately 90% relates back to our past experiences. So if you've experienced, for example, trauma and neglect, the way that you interpret things that are happening right now can often be viewed within the lens of the past and it can color our interpretations of what's happening right now in both a positive and in a negative way. So one thing that we say to people during the pandemic is that, oh, if you could just go back one slide, please, Braden. One thing we often say to people during the pandemic is that when things feel uncontrollable or difficult, it's often helpful to add structure to your life as much as is possible. So we say, for example, it would be helpful to have a routine. So if you're working at home, to really stick to your normal getting up time, your normal bedtime, as much as possible. And it can be quite difficult having children at home to maintain your normal office hours and really set a structure around your life. Because when things around you feel unpredictable, it can be very helpful to add a structure to your life. It's also really important to think about those things that we do have control over. So we do have the control over, for example, our breath. So what if you could stop in the moment and think about your breath and think, I have control over that. I have control over my body, and I have control over, for example, my breath in this moment. And even when things feel unpredictable around me, these are things that I do have control of, and I might want to reflect upon those in the moment when I'm feeling overwhelmed. Let's go ahead one slide, Brayden. We also know, as I had said, that routine is very safe and predictable. And right now, during COVID-19, some people, particularly older adults and people with health vulnerabilities, are feeling more socially isolated. They may also be experiencing a sense of loss, so a loss of the life that they had before, a loss of the ability to go out and have control over when they go shopping, or when they see their families, when they see their friends. And that sense of social isolation, we know, is a risk for the development of PTSD as a result of stress and trauma. So what I'd like to say here is that when people are at home alone, as much as possible, to try to use ways of reaching out. That could be through the telephone. It could be through what we're all becoming very accustomed to with Zoom calls, but really making as many opportunities as you can to come together with others. I often think on Friday night I'm very tired. It's been a long week, but I still try to make that effort to connect with my friends, to connect with my family, because social support and spending time with others is really the most protective factor we have against PTSD. There's been many very fancy, very expensive studies that involve millions of people, but we always find once over and over again is that reaching out for social support is really the best way to protect yourself from PTSD. And we say as well in mental health care, and in particular around depression, often when we think about doing something, it may feel overwhelming. So it might feel overwhelming to make a phone call. It might feel overwhelming, to have a Zoom call online with someone. But what people with depression and people with PTSD often find is that once they're in the moment, having that call, talking to a friend, talking to a family member, it actually feels quite good for most people in the moment. So it can be very difficult to get to that point, but once you do it, often you'll find that it can be quite an enjoyable experience and really reinforces, again, keeping that social contact, being in contact with others. Let's go ahead, Braden. I wanted to talk a little bit about homeschooling as well, because I know for parents in the audience, really this could be a very challenging time having kids at home, and then also making what I think are incredibly difficult decisions about whether or not to send your child back to school at this time. Certainly having this change in the environment for the child being at home, as well as for the parent coping with a child while also trying to work, this can really lead to an increase in stress in a household or stress within a family. What I would really encourage parents, as well as children who are at home, to think about is what has helped you in the past when you've felt overwhelmed. So thinking back to other times that have been quite overwhelming. Did, for example, taking time out to have a bath, having a cup of tea, holding that cup of tea in your hand, feeling the warmth of the teacup in your hand, reaching out to a friend for a phone call. I'd like you to really think about when you're experiencing that stress, about things that have helped you in the past, and then think about, would you like to use those again in this moment to help with the stress that you're experiencing right now? We talk a lot in mental health care and trauma about something called grounding. And really what grounding is using your five senses to help you ground in the moment. So one way that we might do that, for example, when we're feeling very overwhelmed or aroused, is to put our feet on the floor and to really focus on the sensation of your feet on the ground. And I encourage people in the audience to do that right now. So to place your feet on the floor and really pay attention to the feeling of your foot on that floor. And then I'd like you to imagine roots, so just like the roots of a plant, growing from your feet into the ground and holding you in place. And this is often a way, this grounding technique is a way that we can help to overcome some of those overwhelming emotions that we might be experiencing during COVID-19. We could also use other senses like touch. So some people find, for example, holding an ice cube in their hand and just experiencing that ice cube melting in the hand can be very grounding. Other people use taste. So putting a candy in your mouth and rather than just sucking on that mindlessly as we normally do, really paying attention to the sensation of the candy in your mouth, the feeling of it on your tongue, the taste that it has, and really focusing upon that moment and that experience to help to ground yourself. You could also use a familiar scent or one that you like peppermint or vanilla, or any scent that you really prefer, and just smelling that scent and being in the moment and experiencing that and really focusing upon that. That's often a way to really help with feeling overwhelmed in the moment. And these techniques may also be helpful for your children as well, who are experiencing stress during this time of homeschooling or going back to school. As Andrew had said, for some people, the response to stress and trauma is very different in terms of becoming under aroused. So this is a person who's not present in the moment. They may feel very numbed out. They may have difficulty connecting with other people around them. And I'm going to bring that picture up again in a moment that Andrew showed. This is someone who really is not present in the moment. For kids who seem very numbed out during COVID-19, who seem not present and really overwhelmed, as well as for parents, really providing sensory stimulation can be very helpful. So playing games that involve throwing balls, feeling the sensation of the balls, maybe using some fidgeters, which many kids I know now use, but really providing sensory input to help bring that person back into the moment. Oops, and we'll just go one side ahead, Braden. As I said, what we really need to remember, and I know I work in the healthcare community as well, and I know people on this call do, as well as in many other industries like the steel industry. We need to remember that we're together but not alone. And that social support is the single greatest predictor, again, of who develops PTSD. So really reaching out to those around you, reaching out to community organizations, reaching out to get that support from others that you need is also incredibly important during this time. So I just want to go back to just to focus a little bit on some of the research that we do in our lab. And I wanted to talk a little bit about adverse childhood experiences. And we certainly know that having childhood adversity has impact on individuals across the lifespan. So that includes impact on both their mental health and on their physical health. So individuals who have experienced adverse childhood events are more likely to develop PTSD, more likely to develop anxiety and depression, but also more likely to have a physical burden as well. So they may have higher blood pressure, more heart disease, diabetes, and those experiences during childhood continue to impact us well into adulthood. And I think it's very important to remember that rates of childhood adversity are probably a bit higher than we think. So this was a study of about 17,000 middle-class working individuals in the United States back in 1998. And when this result came out, people were quite surprised to learn that about 30% of individuals of these 17,000 adults reported having experienced physical abuse during childhood. 20% reported having experienced sexual abuse, and 19% had parents who had a mental illness. And I think that's just really important to remember when we think about our responses again to the COVID pandemic, that often what we experienced in the past can also drive how we're feeling in the present moment. Maybe Braden, if you could just advance to the next slide. So we know that for many of these individuals during COVID-19, there can be a feeling that having a lack of control over one's own body and one's own space. And that many people can experience that, healthcare providers, employers, employees. And we know that many of these individuals, like government, are telling us how we should act right now, what we should do, where we should be. And that can be triggering for many people who have a history of trauma. I think that's just very important to remember. But I also want to say that I had an experience many years ago as a clinician where I was interviewing a woman who had been kidnapped in Mexico City. And she was telling me about her experience. And I said, you know, that's really awful. And she said to me, no, for me, it wasn't awful because it had happened before. And it was something that had happened to many of my family members, and I knew I would be okay. And I think it's important to remember during COVID-19 that for people who have a history of trauma in particular, we can't assume that we know what their response is to the pandemic. I've spoken to many people with PTSD and with a history of trauma over the course of the pandemic. And many of them say things like, this is everything that I ever expected. And others now know what I live through every day. So again, not everyone has the same response. For people who have PTSD, they may feel as if all their expectations are coming true. They may feel as if maybe now others can appreciate the sense of danger that they feel or terror that they feel day to day as a result of their trauma. And some will say, in fact, that I'm doing fine. This is the way that I live my life every day. It's just that it's happening to everyone else as well. For individuals, though, who are exposed to stress, like the COVID-19 pandemic and other forms of trauma, it is also important to remember that there are typical responses to trauma, and that the intensity of that response may vary with the severity of trauma. And the severity of COVID-19 really will differ among us as individuals. Some of this will experience this as highly traumatic. Some of us will find it, to be a stressor, but manageable. And others won't find this traumatic at all. And it's really important to remember that when we think about the impact of COVID-19 on ourselves and on others, that we tend to have very different responses to it. But among individuals who find it highly traumatic, some of the typical responses that we would see to a traumatic incident could include, for example, re-experiencing. So having recurrent thoughts, our dreams, our flashbacks or images related to the trauma. And some of us who experience the COVID-19 pandemic as being highly traumatic may experience an intense emotional reaction. So feeling very fearful, feeling very anger, a sense of helplessness, or a sense of despair. And all of us as individuals will vary on that continuum. So there may be times, for example, where we do feel quite helpless about what's happening right now, and really again have that sense that we don't know where it will end, but the intensity of that will vary among individuals. For people who find it highly traumatic, they may become very vigilant and they may experience a lot of arousal in their bodies. Others, as I mentioned, may numb out or not seem very present in the moment around them. It's also very true that in trauma and in depression, that it's not just experiencing negative emotions like anger or fear or helplessness or despair, but also having difficulty experiencing positive emotions. So it can be very powerful to say to someone who's experiencing PTSD or depression that I understand that it's not just that you feel sad or down or afraid, but also that you're having difficulty experiencing joy or happiness or having a sense of pride in yourself. It can actually, for people who have a history of trauma, receiving a compliment can actually feel like it hurts. It hurts to hear someone complimenting you because you had not been complimented in the past. And when people had who are meant to have a sense of pride in you or to compliment you on your accomplishments didn't, hearing that as an adult can actually feel quite painful. And I think it's really important just to remember that when we talk about PTSD and trauma. We do know that among many individuals exposed to traumatic events, like the onset of the COVID-19 pandemic, that we experience a gradual adjustment over weeks. I know for myself, and I noticed this in many of my colleagues and my friends, that in the first couple of months of the pandemic, I noticed that people really were struggling with the pandemic and their experiences, and they were having good days and bad days. And for some people, certainly not all people, but for some people, over time, this seemed to diminish and there was less of that traumatic response or that stress response over time. And if we go to the next slide, what I just wanted to highlight on the next slide is that, a couple of things. So that, immediately following a trauma, and that's what we're really seeing in this graph, just a major trauma like, for example, an earthquake or an earthquake or being in a car crash, about 94% of people will show symptoms related to PTSD in the first week after that trauma. About 3 months later, 47% will continue to show some symptoms, and then 42% within 9 months. But looking at many years out, what we actually see is that many people, in fact, do recover from their traumatic experience, between 75 to 85%. And I just want to speak myself as someone who had PTSD as a result of an airline incident and who received treatment, an airline crash, in fact. I actually did recover from that PTSD with proper treatment. And I think it's very important to challenge the stigma that surrounds mental illness and the belief that people cannot recover from it. As a graduate student like Braden, when I was at University of Toronto, during my honeymoon, my husband and I were on board an Air Transat plane that was traveling from Toronto to Lisbon, Portugal. And that plane actually ran out of fuel midway over the Atlantic. And I always say to people, it's exactly what you would expect, that people on board were very distressed, were screaming, and we were very fortunate that the plane made it to a joint military civilian airstrip on an island in the Azores. And we made a very rough landing on the island. The plane was on fire and we evacuated the plane. And I actually, with my colleagues, ended up doing a study on the passengers on board that plane, really speaking towards the importance of research in PTSD. And we found that many people on board, in fact, did have PTSD as a result of the incident. But as well, many went on to receive treatment and many, if not most, recovered. And that includes myself. So I always wanted to help people that and be very upfront about it, because I think it's very important to challenge the stigma that people who have PTSD or mental illness cannot recover. In fact, they very much can, and they can go on to become clinical psychologists and researchers in this area. I just wanted to highlight that point around challenging stigma. Maybe we can go on to the next slide, Braden, if that's all right. This is a whole host of symptoms related to PTSD, and I'm not going to go through all of these, but just to highlight that PTSD can present in different ways in different people, and that's a lot of the work that we've been doing in our lab, is really to understand how does PTSD impact upon us as individuals. And certainly Andrew showed us quite a bit of data showing us, for example, that the brains of people who have PTSD differ in terms of what type of PTSD they have, whether they're very hypervigilant, very aroused, or whether they're quite numbed out or not present in the moment. In fact, their brains look quite different. And that's really work, again, that the Jonathan and Joshua Memorial Fund has really provided support for, and we're very grateful for that. Maybe we can go to the next slide, Braden. And again, really, when we think about PTSD, a lot of the work that we have done in our lab has really, this was Ruth Lanius was the first person really to identify this, is that for some people who have PTSD, they'll look very much like the soldier on the left, who really he really is, you can see that he's quite hyper aroused, that he's crying, he looks quite distressed. And I would imagine that his body also feels very tense, and that really he's experiencing symptoms of being quite aroused, over-aroused, within him. And I want to just make that point around the body, because that's something that in our lab and in our group, we pay a great deal of attention to. So we often think about mental illness as being in our head, and certainly that's true, that our brain and our body, our brain and our mental health, our mental state plays a very large role in mental health. But also we also say that trauma, that the body keeps a score in trauma. And often we encode those traumatic memories in our body. So we would, if we pay attention to our body, for example, after we've experienced a trauma or during times of great stress, we might feel a great deal of tension in our arms, in our legs. We may feel quite ill in our stomach, and that really is the body responding to stress and trauma. And we work within our lab to try to identify new treatments that target not only the brain, but also the body in terms of the body's response to stress and trauma. And some of the work that we're doing right now is really translating treatments that were used originally for children that involved using sensory input. So things that would stimulate the body in terms of, for example, large balls that are quite soft and pliable. And using some of that sensory input, we're hoping that that will calm down some of the arousal in the adult brain as well. As Andrew, both Andrew and I had mentioned, for other people who experience PTSD, they really are quite hypo-aroused. They're numbed out and they're not present in the world around them. And I can remember as a clinician seeing military members and soldiers who had this type of PTSD, and they would come to my office. And even as a clinician, I had a tremendous sense of sadness when they would leave with this very numbed out state, which is actually more difficult to treat, and where we really do need research, like the sort of work that's being done by Braden and Andrew and Ruth and other members of our group, to really understand, what does this presentation of PTSD look like in the brain? What areas do we need to target that are different from what we see in a more typical presentation of PTSD? What drugs might work differently in these individuals, and what talk therapies or what behavioral therapies might have a different effect on the individual on the right as opposed to the individual on the left. And I think research is tremendously important in advancing that search for treatments for different types of PTSD. Maybe we'll move ahead, Braden. Just to give you a sense of what someone might experience when they're having a response like that military member on the right-hand side of the picture. So people can say things, for example, that I was outside of my body looking down upon myself. It was too overwhelming to recall the traumatic memory. They might say, I just felt completely zoned out and I could not tell what I was feeling. And you could imagine yourself that during a time of tremendous trauma and stress, so for example, being an individual experiencing a sexual assault, it's actually quite adaptive not to be in your body while that's happening. So people may report, for example, during an assault, that they almost felt as if they were separated from their body or that they were floating above it. And that's the brain's way of coping with stress and trauma. When you don't feel connected to your body, you won't experience the pain of an assault in the same way that you would if you were feeling very present in the body or connected. And so at the time that a trauma is experienced, that's quite an adaptive response. But over time, if you remain disconnected from your body and not present in the world around you, that's actually not adaptive, and it makes it much more difficult to cope. And really, as Andrew said, does require specialized treatment. That's the sort of work that we're doing in our group. We'll just skip ahead for this. Like Andrew's already shown us the differences and how the brains look in the individual on the right and the individuals on the left, that really he and others in our group have identified using MRI imaging to look at how the brains of individuals who are quite over-aroused and under-aroused look different. And if we have knowledge of how those brains look different, of their differences in their structure or differences in the way that they respond, then we can think about treatments that target directly those specific brain regions that look different between different types of PTSD or respond differently in different types of PTSD. So I did want to talk to you today a bit about something called the mental health continuum model. And this is a model that was developed by the military to assist soldiers and civilians who were going to Afghanistan, Rwanda, Iraq, to really help prepare them for some of the stresses that they might experience during deployment. And I think that this model, which we use in our group, is also helpful for us now during difficult times as well. And what we want to think about on this mental health continuum model is much like how we think about a traffic light. So green is healthy or go. And this is where, we're taking things in stride. We have normal mood fluctuations that aren't overwhelming for us. We're physically well, and we have a good energy level. And our use of substances are, maladaptive coping mechanisms like gambling is in check, is under control. When we experience a stressor, for many of us, we do have a reaction. So that can include the COVID-19 pandemic, where we're reacting to that stress. And at that time, we might become more irritable or impatient. We might become nervous. We may have a sense of sadness or feeling overwhelmed. And we start to do things that we wouldn't normally do. So we might, for example, become a bit sarcastic. We might procrastinate, become forgetful. And, we may start to have some difficulty sleeping. And I know so many people reported that when COVID started, that they were having some difficulty sleeping. They were having intrusive thoughts about the pandemic, nightmares. They might start to decrease their activity or socializing. And they might start to have more regular use of alcohol and gambling. And when this is happening, we want to be aware, because this is a point where we can start to turn things around, right? Before it goes so far that it becomes quite impairing for us or for others around us. This is a time when you notice this happening. You may, for example, want to think about things like some of the techniques that we talked about today, reaching out to your family doctor if you're having difficulty sleeping, trying to socialize and be with others around you. And really also being very mindful of our use of alcohol or drugs or gambling or other things that really in the long run will harm us. Being mindful of that can really help us to turn things around as well, to think, I'm noticing that I'm having a few more drinks at night. Maybe that's not the healthiest way to respond right now. And maybe if I become more mindful of that and pay attention, I'm going to be less likely to do that. Sometimes though, we really, things do get worse, and that certainly is expected, and the fault of no one that they think that things can become worse with our mental health. So at a time when, we've experienced a trauma or a stressor, we really may notice that we're quite injured, and that would be the orange light on the traffic light. So I know for myself, my warning signs are when I become quite irritable, and that for me is reacting. If I find myself becoming quite angry all the time, I really do know that there's something going on, that I need to pay close attention to that. At this point of injury, we may be experiencing anxiety, feeling really sad or hopeless much of the time. And we'll feel that in our body as well, increased aches and pains, fatigue, avoiding others. And here's where we really do want to reach out actively for help. We know now that we're injured and we need to reach out for the assistance that we need. This could be things like reaching out to your family physician and talking about some of these symptoms that you're experiencing. Looking for resources online that can also assist you. Canada has a Wellness Together portal that's available to all Canadians free of charge throughout the pandemic. And we'll be happy to send that information out after the webinar. But you can reach out to that website and actually receive free mental health care from the Government of Canada to support you during this very difficult time. And others will reach the point where they really are quite ill. These are people who are having angry outbursts and aggression. They may be experiencing depression or suicidal thoughts. And this is where we really do need in the moment to react. So, and that reaction really does need to be reaching out and looking for help immediately. And if we're noticing these symptoms in others around us, we also want to help them to receive help. We certainly say around suicide that, in fact, we need to talk about it. So when we notice someone, for example, who might be seeming quite hopeless and really feeling, that things are there will not be an end in sight to this, and seeming quite down. They might be, giving away their possessions and other warning signs of suicide. The best thing to do at that point is to talk to that individual and ask them if that's how they're feeling, and then help them to reach out for the appropriate supports or help. That really is important, not to have silence around suicide, but rather to address it head on. So if we've used this continuum model, we certainly have learned a few lessons about it. And maybe we could advance to the next slide, Braden. So for us, as I said earlier, it's really important when we're mindful of this model, whether we're in green or yellow or orange or red, to be very aware of what are your own warning signs. When do you find that you're getting in trouble? As I said earlier, for me, when I become irritable, I know there's something wrong. When I become very angry, there's something going on. That's my warning sign for me. And it's really important for me in that moment to think about what has worked in the past. What has helped me in the past? So again, reaching back and thinking about what's helped us in the past can often be very helpful in the moment. But sometimes we reach a point where we really do need to reach out to others for assistance. And I would really encourage people to do that during these difficult times. As well, the thing that we have learned is that when people do come to us for help, especially as employers, so I work as the associate chair of our department, and it's really important when people come to me and talk about their trauma and difficulty they're experiencing, to really witness and to believe what they've experienced, and then to take action. So it's really important for all of us to be armed with knowledge around who to go to when we're experiencing mental health difficulties. If someone comes to us with saying to us, I really am experiencing difficulties, can you help me? And that could be a peer in healthcare, it could be a family member, it could be a friend, to think about what are the next steps and really to prepare for that. So for example, as employers, to have available information where people can go for help if they're experiencing difficulties. So healthcare workers, what we know is that there have been a number of surveys among healthcare workers during the COVID-19 pandemic. And really one of the things that healthcare workers have said is that it's really important for organizations and for the government and for others to see me, to protect me, to prepare me, to support me, and to care for me. And I would include in that to include me and to tell me. And let me tell you a little bit more about that. So healthcare workers talk about how they're not sure that their leaders recognize some of the most pressing concerns of healthcare professionals who are on the front line. And that that the resources of organizations may not be being deployed in a way that's always helpful to healthcare workers. So what we would argue is that during times of uncertainty like the COVID-19 pandemic, this is important not just for hospitals and government, but also for any organization to really create an array of input and feedback channels. So to have town halls for your community, to provide opportunities for people at the front lines to give feedback and also to assist in decision making. So often decisions come from the top, but it's really important for individuals who are at the front lines to also contribute to decision making. So if, for example, there was a limited supply of masks that were available, we might come together as a group to decide who among us is most at risk, who has the most direct exposure to COVID-19, and do we want to allocate those masks based on who's most at risk and who's least at risk. If people are involved in that decision making, they often feel a lot better about the decisions that are being made. Healthcare workers are also saying, protect me. So, and this is true in all organizations. So having adequate personal protective equipment available, rapid access to information about how you can protect yourself, and having a realistic sense of what the risks are. So we don't want to be a Pollyanna during the pandemic and say that there are no risks. We also want to have a realistic sense of what those risks are, and having that information provided could be very helpful. We also hear about Prepare Me, and this is really providing adequate training and basic knowledge about how to handle the pandemic and its risks and the virus and its risks. And when people have information about what they can do, they often feel more comfortable. We certainly have found within our hospital that when people were working at home, many people were working at home at the start of the pandemic, many people were very anxious about coming back to the hospital. And we found when they had information and supports that they actually did feel more comfortable when they came back. And just being there and being present and knowing that you have some control can often help to alleviate some of that anxiety. It's also very important to feel supported. So knowing that your personal needs and your family's needs are being met during this difficult time. And certainly parents are experiencing a great deal of stress right now, thinking about their children going back to school and not knowing how they're going to accommodate both working, having to pick kids up at school at 1 o'clock when normally they would be there for the full school day, rotating school days, and how can employers and organizations support the needs of their workers during this time and also ensure that there's also space for work to be done. This is very challenging, and I think again having a plan and working together to problem solve can be very helpful as well. Finally, healthcare workers are saying, care for me. So many healthcare workers and individuals, people who are working, for example, in construction, people who are working fixing vehicles and being exposed to others who may have the pandemic, they're all saying, I really don't want to bring this home to my family. What happens if I encounter COVID-19 at work and I bring it home to my family? People want to hear how they would be cared for, but also how their families would be cared for if something happened. And I think that's a very important message that organizations can give their employees, is talking concretely about this is how, if something, heaven forbid, did happen, this is how we would support you. This is how we would support your family. That can be very, very important to individuals during this difficult time. I want to say, if it's okay, just a few more words about a concept called moral injury that we've been examining. And Brady, if you can just skip ahead to the next couple of slides. So we do know that for many individuals during the pandemic, they're really struggling with some of the moral decisions that they have to make. This can be, for example, providing health care to an older adult who really doesn't want to receive that right now, but the family is saying, I think they have a chance of surviving. Let's go ahead with that care. It can be a feeling that, for example, by going to work, we're increasing risk to our families that wouldn't be there otherwise. And that sense of what we would call moral injury can be very distressing to individuals. We really want to help to identify that, there are unique ethical and moral challenges associated with this pandemic. And part of the antidote or the tonic to that moral distress that people are experiencing is being very open about that, discussing it, again, coming together as a group to problem solve, but also having a sense that there will be situations where situations will not be black and white, they will be gray, and we'll need to work together to solve those. So I just wanted to make that point as well before I close this talk.
Thank you, Braden. So today I'd like to talk about some of the neuroimaging research that we've been doing in individuals who have been exposed to traumatic events and have subsequently developed post-traumatic stress disorder, and how I believe we can really utilize and leverage this research to develop novel treatment interventions for PTSD. So today what I'm going to talk about, firstly, on the outline slide, if Braden, you want to go to the next one. So first, I just want to talk about really what the problem is, and that is the high rates of development of PTSD and suboptimal treatments, and really two areas that our research aims to improve. So first, understanding the underlying neurobiology of PTSD and how we can use this by, for example, leveraging, say, machine learning to identify new subtypes of illness. And then also, once we understand neural targets for treatment that are associated with PTSD, how can we enhance current treatments that we have by developing novel adjunctive treatments? And then we can go to the next slide. So first, I would just like to thank both the Jonathan and Joshua Memorial Fund, as well as Bob Mckinnon, for both having us today to present this webinar, but also for their continued support over the last 5 years. So they have really been instrumental in enabling us to conduct both important research on the neurobiological level, so how we can better understand this illness, but also in terms of how we can develop novel treatments. And recently myself, Margaret, and Ruth have collaborated as well with Braden, who's mediating this talk in a recent publication, for example, that was published in 2020, but we've also, these are just some examples of the research that this fund has really been facilitating over the last 5 years. We're extremely, extremely grateful for that. And moving forward, just on a personal note, we can go to the next slide, is I was also fortunate enough, sorry, Braden, one slide back. One more, sorry. Perfect. So I was also fortunate enough, like Braden, when I was at Western University, to be the recipient of this graduate scholarship. And then since then, I went on to do 2 postdocs at the University of Vienna and University of Zurich in Switzerland. But really, this Memorial Fund and Bob Mckinnon have been instrumental in being, and for me to be able to come back to Canada and contribute to this research effort at McMaster University and the Homewood Research Institute. So I'm also very personally thankful for that. And I believe this Memorial Fund is really doing great things in advancing how we understand psychiatric illness and how we can improve treatment outcomes. So going into what I would like to talk to you about today, firstly, that is presenting what the problem is, and that's the development and suboptimal treatment of post-traumatic stress disorder. And on the next slide, we know from the World Health Organization that trauma rates are extremely high, so 70% internationally. And of those people who are exposed to traumatic events, almost 30% of people will develop post-traumatic stress disorder, or PTSD. And this is characterized by really intrusive, severe recollections of the trauma, so very vivid re-experiencing, avoidance of trauma-related stimuli, as well as avoidance of thoughts that are related to the trauma. There's also significant changes in arousal and reactivity. So patients often report being very hypervigilant and being in this constant fight or flight defensive response, both psychologically as well as physiologically in their body. And there's also a lot of changes in reactivity, aggression, as well as dissociation, which I'll talk a little bit about later. And then going forward, this image actually is, well, for example, PTSD is associated with 20% of sexual assault cases worldwide. And I chose this image actually based on a television series that recently came out in the popular media, and it is based on the real life story of Marie Adler, who at the time was 18 years old and had been raped and was re-victimized by the current treatments that were available to her, as well as by detectives when they were going through and trying to mediate this traumatic experience that happened to this person. And the reason I included this was because I thought that this series did a great job of depicting life guilt and the shame that goes along with trauma. So for example, I'm a bad person, I deserve this to happen to me, as well as significant changes or experiences of anger, as well as changes in cognition, dissociation, so time lapses and being completely zoned out. So one scene that really stuck with me was there's a scene where this individual is driving and she stops at a street light and completely dissociates because she's triggered by her trauma, and then kind of comes back to her senses, so to speak, and drives through a red light and almost gets in an accident. So these are kind of maybe symptoms that we don't typically associate with trauma, but I felt this series did a great job of that. Moving forward, PTSD is also very highly prevalent in Canadian Armed Forces personnel, as well as first responders worldwide. And going to the next, it's also very prevalent among Canadian police officers as well, so about 8%. And this is a very interesting study that was conducted in Canada. And here, researchers looked at over 6,000 public safety personnel And here, almost half of them screened positive for one or more health disorders. And Margaret will go into this more in detail in her presentation, but this number is estimated to be largely underestimated in light of the COVID-19 pandemic, where first responders, nurses, and doctors are faced with very moral, injurious, and traumatic experiences that they have to cope with. And what really kind of complicates the story further is that PTSD is characterized by heterogeneous symptom presentations, so including a dissociative subtype, complex PTSD diagnoses. So this poses additional considerations for treatment, and it's clear that PTSD models of treatment must really move beyond a one-size-fits-all kind of conceptualization and move into a more personalized medicine approach if we're going to be able to sufficiently reflect the complexity of this illness. With regard to the treatment of PTSD, some very important things are, we know dropout rates are extremely high. So for example, 1 in 3 patients will drop out of evidence-based psychotherapies in veteran populations. And although we have strong treatment programs available right now, we know that treatment options and current treatment approaches are not always effective in all patients. And novel personalized medicine approaches are therefore really in demand for the treatment of this disorder. And on the bottom of the screen, we can see if this is kind of the range of PTSD symptoms. If we go to the next slide, our current evidence-based psychotherapies and approaches that we have available are getting treatments down to here, reducing symptoms to here, and we really want to get it down to here. So reduce those as much as we can. So now I would like to go into how we can actually understand the neurobiology of PTSD and its subtypes. So we know that the development and the treatments that we have available for PTSD are not always effective, but how can we actually understand the underlying neurobiological mechanisms of PTSD, and how might that inform treatment approaches so we can optimize those treatments that we have available? So this slide here is just showing in between the blue lines, kind of the optimal range of arousal and stress reactivity in humans. And on the next, we see that individuals with PTSD will oscillate on the upper spectrum of this range of arousal and stress. So they will have a lot of symptoms of hyperarousal and very intense emotions, active fight or flight responses, as well as vivid re-experiencing of their trauma. Inversely, there's a subtype of post-traumatic stress that's characterized by about 30% of patients, and they actually are very shut down from their emotions, and they are disconnected from their emotions, and they experience a lot of symptoms of depersonalization. So out-of-body experiences being removed from their body psychologically, as well as derealization, where their environment appears to be dreamlike or unreal. So this is not happening to me at this moment, it's all a dream. Also, they can be very removed and shut down, and this poses additional considerations, for example, for evidence-based therapies. So if someone's not able to get in touch with their emotions, if they're removed and shut down and not embodied, this can pose considerations for treatment. And as you can see here, this is just an image of a soldier who is very disconnected and dissociated during treatment. And some examples of dissociative responses to kind of paint a picture clinically, these are quotes from patients that say, when I was triggered by my trauma, I was outside my body looking down at myself. It was too overwhelming to recall the traumatic memory. I was completely zoned out and could not tell what I was feeling. So again, showing that they are not embodied, they're zoned out, removed from their body psychologically, or I was looking down at my body while reliving the trauma. And on the next slide, I'm just presenting kind of some risk factors, because you might be wondering, why might an individual develop dissociative subtype PTSD as compared to the more commonly seen 70% of patients displaying these classical forms of post-traumatic stress? And dissociative subtype is more associated with childhood onset of symptoms, higher exposure to trauma, particularly in childhood, and more severe PTSD symptoms. And it's been hypothesized actually that this dissociation, so kind of checking out psychologically, may be an adaptive mechanism to restrict these unwanted emotional states and facilitate psychological escape from repeated exposure to trauma, especially when this may not be possible as a child. So these are kind of the risk factors for dissociative subtype, for example. And interestingly, on the neurobiological basis, we see that the brain looks very different in PTSD versus dissociative subtype PTSD when they're triggered by their trauma. So if we just go to the next point, that'll bring up 2 images. Yep, so on the left side of the screen, this is 70% of patients displaying this typical hyperarousal and vivid re-experiencing of trauma. And here we call this emotion undermodulation. So the areas in red that are responsible for regulating emotions are not active enough, they're not coming online. And the areas in yellow on the left are becoming too active. So the emotion centers of the brain are dysregulated and show too much activation. Inversely, these about 30% of patients will display these dissociative subtype symptoms of decreased arousal, depersonalization, derealization, emotional numbing, and variations in pain perception, for example. And this is really characterized by emotion overmodulation, so the complete opposite actually. So their emotion regulation centers show too much activation in yellow in the prefrontal cortex, and the emotion centers in red are really shut down actually. So this really shows that the underlying neurobiological basis of the symptoms in both PTSD and dissociative subtype are quite different. And moving forward, and interestingly, this model was actually first proposed by Ruth Lanius in 2010. And since then, myself, Margaret Mckinnon, and Braden included have done a lot of research to really examine the underlying neurobiology of these 2 groups. So for example, this was one study that we did in 2017, where instead of just looking at activation in the brain, we looked at the direction of connections areas. And what we found is that on the left side of the screen, the typical presentation of PTSD, the direction of connections are bottom up. So they're going from those emotion generation areas up towards consciousness, towards executive regulation, prefrontal areas. Whereas in dissociative subtype, the direction of connections are actually going from these emotion regulation areas down and shutting off these emotion centers. And then on the next slide, this is really summarizing a collection of work that's been done over the last 10 years with Ruth Lanius, Braden, Shireen, who was a PhD student with Ruth Lanius and who's now doing a postdoc with Margaret Mckinnon. And really what this body of research shows is that during the resting state, which means not just when patients are being triggered by their, or for example, shown photos that are meant to elicit emotions. In the resting state, when they're just lying in the scanner and we're looking at brain activation and connectivity, they show very different connections in the brain across the entire neural axis. So from the prefrontal cortex down to the cerebellum. And we see these differences when comparing PTSD, dissociative subtype in healthy individuals. So it really kind of poses the question, how are we treating these brains differently in first-line treatments for post-traumatic stress? And just kind of a recap so far. Firstly, we know there's unique symptom presentation between PTSD and dissociative subtype PTSD, where the majority of PTSD patients showing that hyperarousal, fight or flight, avoidance symptoms, and dissociative subtype really showing that emotional shutdown, out-of-body experiences, derealization, and emotional numbing. And those correspond to opposing patterns in the brain, both during trauma triggers, as well as when looking at directed connectivity on the next point. And on the next point, also differences in resting state connectivity in the brain. So here, moving forward, collectively, this evidence suggests that, for example, two things: that we might use machine learning algorithms to look at these patterns of activation in the brain to classify and diagnose patients, but also maybe we could use this information to better inform neurobiologically or to have more neurobiologically informed adjunctive treatments for this illness. So on the next slide, into how we've begun to use this research to inform treatment interventions, I would just like to talk about a machine learning study that we did in 2018, where we used all of this neuroimaging data to classify patients. And you might be asking, what is neuroimaging machine learning? So machine learning algorithms, what's unique about them with respect to neuroimaging is that they can learn distributed patterns of brain data to make clinical predictions. So if you think of brain imaging data as a photograph with all of these pixels, which we call voxels in MRI, machine learning can not only, as compared to classical analyses in neuroimaging, just identify regions of the brain that show differences in activation. Machine learning can actually learn from this pattern of pixels that are in the image to make clinical predictions on the individual subject level. So we can predict risk, development of the illness, and response to treatment. And a key part of this is that these analyses are powerful enough to make inferences at the individual level, so relevant for individual predictions of patients, whereas other machine learning analyses typically need to be done on a group level. So on the next slide, I'm just going to discuss now the study that we did in 2018 with Ruth Lanius and Margaret Mckinnon that was published in Psychological Medicine. And here what we were able to do using just resting state brain activation, we can go to the next slide. Just using resting state brain activation, so individuals with PTSD, dissociative subtype PTSD, and healthy individuals were just lying in the scanner, and we took brain images over a 6-minute scan. So using those images, we were able to classify diagnosis with 91% accuracy to classify these three groups, so healthy individuals from PTSD and dissociative subtype PTSD. So on the bottom, healthy controls could be classified with about 88% accuracy, PTSD patients with 95%, and PTSD plus DS, which is PTSD dissociative subtype, with about 90% accuracy. And here on the top right, what you see is the areas in red. Those are areas of the brain that were most important in the classification of these groups. And what you see in support of this emotion modulation model, when I showed those two brains with opposing patterns of brain activation, we see that these emotion regulation areas were very important in classifying these groups. And that supports this body of literature that shows that these prefrontal emotion regulation areas either show not enough regulation of emotion centers in PTSD or too much dissociative subtype. So it's really in line with those findings as well. And moving on now, kind of the summary here is that the goal really is to better understand and accurately classify patients based on different subtypes of PTSD, so we can really match specific individuals to a treatment intervention that will be most optimal for them. So really, in who and what on the neurobiological level are we really treating? And some future directions or visions that we have actually is to extend these machine learning classifications to more cost-effective modalities. So using things like EEG, which is a portable headset that goes on the scalp, which just measures voltage potentials across the brain. This is very cost-effective and portable in comparison to neuroimaging. So to use this actually to make clinical diagnostic predictions as well as predict response to treatment. And right now we're in the process of analyzing this big data set that we have with the Homewood Research Institute in Guelph in collaboration with Western and Queen's University to see if we can further classify additional subtypes of PTSD and predict response to treatment in that data set. So it's a very large data set with PTSD patients that were treated at the Homewood Health Institute in Guelph. And then moving forward now to the next slide. Getting to kind of the latter part of my talk now, I would like to discuss how, for example, defining these neural targets, how can we then target those specifically to enhance treatments and develop novel adjunctive protocols for patients with PTSD. And here specifically, I will talk about neurofeedback as an adjunctive treatment for post-traumatic stress. So you might be asking, what is neurofeedback? And neurofeedback is an example of a brain-computer interface. It's non-invasive, so what it does is it measures some activation in the brain, feeds this back to a participant, and then they attempt to gain control over this signal. So for example, the image here is a brain-computer interface with a prosthetic, and they are using EEG signals on the scalp to gain control, moving that arm. Here, what we want to do is use MRI and EEG as well, but to gain control over brainwave oscillations and brain activation that is associated with symptoms. So moving to the next point, here, for example, neurofeedback for PTSD, patients are trying to regulate neural activity that's associated with their symptoms. And this allows individuals to search for individualized cognitive strategies that allow them to gain control over these brain areas, and then as a result, regulate their symptoms that are associated with that brain area. And moving to the next 2 points. So both real-time fMRI-based neurofeedback and EEG neurofeedback have shown promising results for reducing symptoms in PTSD, and they both provide information about brain activity that we normally wouldn't have. So normally I don't know, for example, how active my amygdala is, so this emotion center in the brain. But these types of neurofeedbacks can give individuals a signal that indicates how active or how deactivated that area is. And I say real-time fMRI neuroimaging because typically neuroimaging, we would analyze all of that offline. So we acquire the brain scans and look at that data offline, and that usually is very computationally expensive. But recent advancements have allowed very localized, so small areas of the brain, we can process that in real time and then feed that back to the participant while they're in the scanner. And the EEG is measuring voltage potentials on the scalp, and that is in true real time, whereas neuroimaging-based neurofeedback, there's about a 6-second to 8-second delay because of the amount of time it takes to process those images. The EEG is in true real time because it's measuring just voltage potentials on the scalp. But the downside to that modality is that the spatial specificity of EEG is not as specific as MRI. So MRI, we have more specific, we can target one very localized area in the brain, but there is a temporal delay. EEG, it's more large scale brain oscillations that we're measuring, but there's a very strong temporal specificity of that neurofeedback. So that's kind of a broad introduction to what neurofeedback is and how we can use different neuroimaging protocols to feedback that signal. And what I'd like to talk about is a collection of papers that we published in our lab that we've had support from the Jonathan Joshua Memorial Fund to do. And this is using neuroimaging to regulate certain areas of the brain. And our most recent one is what I'll share today, our most recent results that is currently in preparation to submit. And moving to the next slide, basically this is the paradigm. So individuals are lying in the scanner and we process brain activation in real time and then feed this back to the individual while in the scanner. So here we looked at posterior cingulate cortex, which is the area of the brain that has been associated with PTSD symptoms and typically shows too much activation when individuals are meant to be regulating their emotions. So when they're trying to bring on these prefrontal areas to regulate emotions, these posterior areas of their brain are too active. So what we're trying to do is decrease that activation. So we're processing this in real time and feeding it back to the participant in the scanner. So they see this screen in front of them, and on either side of the screen, there's 2 thermometers that indicate how active or how deactivated that area is. And this is why words, personalized trauma words that are associated with their traumatic experience. So they're being triggered by their trauma, and they're trying to regulate these brain areas that are associated with their symptoms. So moving to the next slide, the thermometer, the black bars are indicating the activation in the target area, and the orange line would just be baseline. So they know kind of what the baseline activation of that area is. And we asked individuals to downregulate an area associated with emotional experience, and that's tied to their symptoms. And we didn't give them specific instructions on how to regulate this area, because the goal is to try to have more of a top-down approach. So to learn how to, or to learn personalized strategies to regulate this area to change behavior, instead of using behavior to change the brain area. And moving to the next slide, what we found was that when PTSD patients were in the scanner, they were able to successfully downregulate this target area, so the posterior cingulate cortex. And on the right, you just see, this is a graph depicting percent signal change in that area. So the green is a control condition when they're not trying to regulate, and the red shows a condition where we're asking them to decrease activation in that area. So you can see that they're really decreasing activation of the posterior cingulate cortex while being triggered by their trauma. And interestingly, when they downregulated that area, there was also downregulation in all these other areas that are associated with PTSD symptoms. So for example, the amygdala and hippocampus, which are heavily tied to trauma, emotional memory recall, and emotion generation, as well as the dorsal medial prefrontal cortex, which is associated with autobiographical memory as well. So they're kind of shutting down the posterior cingulate cortex, but all of these other areas in the brain that are related to their PTSD symptoms and that typically show too much activation during symptom provocation. And interestingly, when we compared this data to healthy individuals in the scanner, people without a PTSD diagnosis were showing more recruitment of emotion regulation areas in the prefrontal cortex. So they're bringing online this dorsolateral prefrontal cortex area. So I think this is only with one session of neurofeedback, but the goal here would be for PTSD patients to bring online that area more in an effort to regulate their emotions. And interestingly, while individuals were in the scanner, we actually saw decreases in symptoms while they were using neurofeedback to regulate these target areas. So PTSD patients in blue and healthy individuals in red, who instead of being shown trauma words, they were shown very personally distressing words. So while individuals were using neurofeedback, both groups showed a significant decrease in reliving symptoms of that very distressing and traumatic memory. This was more prominent for the PTSD group, and their initial, of course, reliving symptoms were much higher than in healthy individuals. And interestingly, on the next slide, we also saw significant decreases of distress symptoms as well, only in the PTSD group in blue. And on the x-axis, so run 1, 2, 3, and transfer, that's just showing the sessions, or the runs rather, that we did of neurofeedback. This was all in one session within one day, but they were separated into nines, and there was 4 of them. So it's just showing that both distress and reliving symptoms were decreasing in PTSD patients just with one session of neurofeedback while they're being triggered by their trauma. And then kind of the last thing I'd like to talk about before handing over to Margaret is that I would just like to present briefly results of our clinical trial of neurofeedback in PTSD and how this really showed promising evidence of decreased PTSD symptoms and PTSD remission, as well as restored networks in the brain. So on the next point at the bottom of the screen, this is using EEG neurofeedback. So the last study I just presented was with fMRI. Here we're using EEG neurofeedback, which measures the voltage potentials across the scalp using these electrodes. And we pre and post MRI scans so we could see how the brain changes as a result of this neurofeedback. And on the next slide, this is just showing the design, but here, instead of just having one session of neurofeedback, we did 20 weeks in this randomized clinical trial. So 20 sessions of neurofeedback, and we had pre-post resting state scans. And here, this is just showing we had an experimental group who received real neurofeedback and a sham control group who received fake neurofeedback. And we compared how symptoms change as a result of those conditions. And we compared pre-connectivity in the brain. So before neurofeedback, we compared that with healthy individuals as well, so we could better characterize the psychopathology on the neural level. And moving to the next slide, kind of the big picture and takeaway messages of this clinical trial was that this neurofeedback led to plastic changes of normalization in networks in the brain that we know to be disrupted in PTSD. Interestingly, these findings were unique to the experimental group and not the sham control group. And the experimental group only showed reductions in PTSD severity. And PTSD severity reduction scores continue to improve at 3-month follow-up in the experiment. And here, what I need to mention as well, what we were feeding back to participants was brainwave oscillations over the same area, the posterior cingulate cortex that I presented in the real-time fMRI study. So it's using a less specific signal, but with better temporal resolution, and it's using EEG as opposed to fMRI. And the importance of that is EEG is much more cost-effective. It's not as expensive to use EEG as neuroimaging, portable. And this is something that Margaret will discuss as well in her talk, is that especially during the COVID-19 pandemic, where access to care is more difficult than ever, it's really important to have portable treatment interventions that people can use in their home, as well as it's important to have these options when accessing rural communities as well. So this is a quote on the bottom from one of the patients who participated in this study. And they say that it's like someone has gone into my brain and put everything back together. It's like someone has made some connections. And by the end of it, I felt more in control. I didn't feel as out of it, and I felt more together, which I think is a really powerful quote from this patient. And on the next slide, this is showing actually the decreases in CAPS, which is, CAPS is a measure of PTSD severity. So when we do clinical assessments of post-traumatic stress, CAPS would delineate how severe their post-traumatic stress symptoms are. So both the sham group in green, who received fake, not real neurofeedback, but they had psychoeducation with a trauma-informed clinician, and the blue, which is the experimental neurofeedback group who received real neurofeedback, their symptoms did not differ at baseline, and only for the experimental group do they show a significant reduction in clinically meaningful reduction in these PTSD severity scores. So reductions in symptom scores greater than 30%, and these continue to improve at the 3-month follow-up. And interestingly, these changes of these PTSD symptoms were correlated with change in the anterior insula, an area that has been tied to, or positively correlated to PTSD symptoms. So typically when an individual is triggered by their trauma, the anterior insula is hyperactive, and decreases in PTSD symptoms in this study were shown to be negatively correlated to this area. And moving on to the next slide, in summary, 61% of participants in that neurofeedback group no longer met criteria for PTSD. And also there were no dropouts from the neurofeedback groups, which I think speaks to the tolerability of this neurofeedback protocol, because treatment dropout rates really are a critical barrier for psychological therapies. And interestingly, this remission rate of 60% is comparable to that of current gold standard treatments of PTSD. So this may represent an emerging novel adjunctive treatment for post-traumatic stress. And experts in the field, for example, Bessel van der Kolk, who works in Boston and is head of the Boston Trauma Center, has hypothesized and talks about how neurofeedback may be particularly beneficial for people who have been non-responsive to other first-line treatments in the past. And it may be especially helpful for people who have very high levels of anxiety, dissociation, and emotion dysregulation, thereby blocking optimal responses to other forms of trauma-focused therapy. So the next slide, in terms of new research and where we want to go with this, is using real-time fMRI, and a researcher who I am collaborating with and who I did my postdoc fellowship with at the University of Vienna, Frank Chernosky, as well as Ruth Lanius, Margaret Mckinnon, is that we want to look at actually regulating neural networks in the brain as opposed to just a localized area, which I showed before. So because we know that PTSD is affecting kind of the entire neural axis, we want to see if we can regulate these connections between all of these different areas directly using real time. And this is a project that we will begin in the fall, this fall, developing. And I think the next slide is kind of to leave off with some visions for the future. Here is that we want to look at online administration and portable administration of these neurofeedback protocols, which again, Margaret will talk about, and which is underway also this fall. And we also want to look at using neurofeedback specifically in dissociative subtype patients. As I mentioned before, they show very different neural targets and mechanisms for treatment. So it'll be important to develop personalized neurofeedback protocols for those individuals, whereas the majority of the neurofeedback research I've shown today has focused on mediating the neural correlates in non-dissociative patients. And then, so yeah, moving on to the next slide, I would just, like to acknowledge, one more slide, sorry, Braden. One more. Yeah, I would just like to acknowledge that this collection of research has really been a group effort, and it's the result of this Canadian Canadian PTSD network that has enabled all of this research, as well as our support from funders like the Jonathan and Joshua Memorial Fund. So I'd just like to acknowledge Rainis, who couldn't be here today, Margaret Mckinnon, Shireen and Braden, who have been instrumental in all of this research as well. And thank you for tuning in, and it's been a pleasure to kind of share this research and how really the Jonathan Joshua Memorial Fund is advancing psychiatric research and treatment.
Hey, thank you both for participating. So right now we're going to go on to a question period. And so if people that are attendees want to ask a question, I think there's a question box located on the control panel, and they could type in a question. We have a couple of good ones already, but if they want to specifically ask a question either to Margaret or Andrew, feel free to type those in. Otherwise, I'm going to go through the questions that are currently there, as well as some of my own questions, and hopefully we can get a little discussion going. But we're going to keep this discussion hopefully under about half an hour. And so I'll start with a question that we got from Joanna White, and she specifically posed this might be, we'll start with Margaret, with you. Is there any differences in the intensity of PTSD symptoms for people that are getting second-hand contact with individuals that have experienced trauma? So think frontline workers, specifically during this pandemic, nurses in the hospital. Maybe they're not experiencing a traumatic event themselves, but they're definitely experiencing trauma vicariously through the patients that they're then seeing.
Absolutely. No, I really appreciate that question. It's a very important one. And in the past several years, we've really come to better recognize that people in healthcare, first responders and others, experience vicarious traumatization. So that sense that a trauma or an illness or an injury may be happening to someone else, but by bearing witness to that and seeing their distress and the distress of others around them, then we may also experience PTSD as a result of that. And we are certainly hearing from the healthcare community, nurses, respiratory therapists who I talk to routinely, physicians, and many others, that they are experiencing symptoms of PTSD, and some even PTSD as a result of what they're being exposed to during this pandemic. I really do appreciate that question, because the threat of injury or the threat of death doesn't just have to be to yourself for trauma. It could be happening to others, but you may in fact go on to experience great distress, to have traumatic responses, and even to develop PTSD as a result of that exposure. And that's a really important point. So thank you so much for asking.
If I could also add to that, recently there's been a lot of interest in exploring, and we're certainly doing that now with researchers at Queen's University, for example, Heidi Cram, looking at intergenerational vicarious traumatic exposure, and really looking at the whole family unit and family structure in terms of how we treat PTSD as well. So yeah, it's something that we also, I think, need to study more closely as well.
Absolutely.
That's great. That's a great answer to the question. So now I'm going to pivot a little bit into Andrew. So Andrew, we got a question from Paul Calford. Hopefully I'm pronouncing these names correctly, about information regarding NET or KidNet. I think that stands for Narrative Exposure Therapy. And he was specifically talking about EEG and neurofeedback. So maybe I'll start by saying, when we're doing these EEG neurofeedback sessions, is there also a clinical therapy component, or are we just showing participants the neurofeedback and that's the only kind of experimental condition?
Yeah, so it kind of differs for which neurofeedback experiment I was talking about, but for the EEG neurofeedback, for example, that was solely, and in the clinical trial, that was only EEG neurofeedback. So we're trying to look at the very specific effects of EEG, which remission rates were at the same level or on par with standard or frontline gold standard treatments for PTSD. So it'd be really interesting to look at kind of the additive effects of different treatments plus neurofeedback, because it's been hypothesized too that neurofeedback can really get people in the right frame of mind, so to speak, in order to better process their trauma. But for example, if we're talking about the real-time fMRI neurofeedback, that definitely had an exposure component, because they were viewing words that were associated with their trauma, and they're being triggered in a sense, which is in some ways similar to exposure therapy, and then they were trying to regulate their emotions. But yes, definitely something we want to look into is what is kind of the optimal pairing of treatments in terms of neurofeedback and currently available treatments we already have.
And Margaret, on that note, so do you have any familiarity with this narrative exposure therapy as a clinical tool?
Yes, I do. I know it's being used more frequently now for PTSD. I haven't seen specific research related to that now, but I certainly have heard about it. So yes, it is a new treatment offering in PTSD.
Oh, okay, and now I'm going to ask another question to you, Margaret, my own personal question. So when someone successfully reduces their PTSD symptoms, either through neurofeedback or some sort of clinical therapy, such that they no longer meet the criteria, the diagnostic criteria for PTSD, what is the relationship that that person might have with their trauma memory? You can either talk from personal experience or just something that you see in clinical therapy. So like, how are they remembering their traumatic memory? Just like episodically, autobiographically, or is there still an element of fear associated with it?
Yeah, I think that varies very tremendously between individuals. It really would depend on the individual's response. Speaking from personal experience, I was often asked to tell that story over and over and again because people are curious, right? They do, and it's human curiosity. They do, want to hear about it. I found over time, I just told a story to people, right? Like it was just, I have a standard line of details that happened, and I was able to distance myself from that memory. Whereas in the beginning, when I told the story, I would re-experience the event, and that was my personal experience. I've heard others say that, but it differs across individuals. For some people, they may not really be able to give words to their memory, but they'll feel it in their body. So for example, someone who's been assaulted, who might have been stabbed in the arm or stabbed in the chest, they may continue to have pain in that area, that they don't have a specific memory of what they may have dissociated when it happened, not remember the assault, but their body will keep that memory encoded in it. We also see that in survivors of sexual assault, where the regions that were assaulted may experience pain, but a child may be too young to remember the assault.
That's great. So now I'll answer a question for both of you. So I think a commonality between these presentations is that there's these different symptom presentations associated with PTSD. Oftentimes, when we think of PTSD culturally or colloquially, is with regards to hypervigilance, people that are constantly re-engaging with their memories. There's anxiety associated with it, and it's very on the edge of their seat oftentimes. What we're finding now is that there's more dissociative symptom patterns that some people also find they meet the criteria or diagnostic criteria for. So if an individual is experiencing dissociative PTSD, does that suggest that they can't also experience traditional PTSD symptoms, so hypervigilance, or can you fluctuate between the two? I'll pivot that to Andrew, and then I'll come back to you, Margaret.
Sure.
Yeah, I think definitely individuals are oscillating between those two kind of contrasting symptom profiles. And for example, a individual who's more hyper-aroused can experience dissociative symptoms and vice versa. It's more kind of the frequency and the intensity by which people experience those dissociative related symptoms. So depersonalization, out-of-body experiences, derealization, for example, an emotional numbing, that would classify them as a dissociative subtype patient. Margaret, did you want to add to that?
No, I wouldn't add much to that. That I agree that it really is how often you're experiencing one type or the other. So for some people, they are more often numbed out, are not present in the world around them, but then they may fluctuate to, as Andrew said, that very hyper-aroused, overly vigilant state. And it's really important, and research has really started to reveal that when someone experiences a trauma, and if they're numbed out when that trauma occurs, so they're not present, they're numbed out, they're standing off in the corner, not present in the world around them immediately afterwards, they present to the emergency room, and again, they seem just not present, not, quite, their face might look absent or blank. Those are the individuals who have the greatest likelihood of developing PTSD after a major trauma. And that's very interesting to us as researchers. We need to understand why that is. And do those individuals remain in that state, or do they have that more over-aroused presentation of PTSD? What do they look like over time as well? But again, as Andrew has shown, identifying those differences in the way the brain responds to trauma among individuals who are hyper or hypo-aroused will help us to develop new treatments and therapies that will be unique to those individuals. And also we could think about therapies in the immediate aftermath of the trauma, where we could prevent people from going on to develop PTSD. And that really is the goal in many ways, is to have people who have been exposed to trauma, it's not just treating them once they develop PTSD, it's also preventing PTSD from occurring as well.
Thanks. So Margaret, at the end of your presentation, you mentioned that uncertainty or unpredictability during childhood is associated with a vulnerability to develop PTSD post-trauma. And then we also look at today's time with COVID-19, and we're seeing that many people have those similar issues. We don't really know what the future is going to look like. We don't know if there's going to be a second wave. So there's a lot of uncertainty and unpredictability. Would then resiliency, which is often a word that's kind of the opposite of post-traumatic stress disorder or post-traumatic growth, then be some sort of like internal or mental framing towards embracing change? So is embracing change kind of protect you in essence from developing PTSD, or a mentality towards that?
Yeah, that's a great question, Braden. So, sometimes it is important. It's kind of colloquial to say that we need to look for the silver lining in these things, but we do. So I can tell you, for example, last night I was having dinner with some friends outside and was saying to them, I've never appreciated you more than I do right now because I've been separated from you for some time, right? And this summer we've spent so much time together because we're able to come together again. And I think having a mindfulness for that sense of connection for what we lost, but again, now have access to again, I think that can help to, ward off some of these symptoms. Not to say that that's the only thing, and that you can still have that sense of thankfulness or gratitude and still go on to develop PTSD, but it does help to reflect upon what are some of those silver linings that come out of a very difficult situation.
So we also got a few more questions from Joanna White. The first, I think, is in regards to CBD, or cannabidiol, one of the more the ingredients in tea or marijuana, which is, of course, just recently legalized in Canada. So do we often see CBD as being implemented as kind of an adjunctive, I guess, natural pharmaceutical kind of to assist with clinical therapies? And how effective, either personally or through the literature, do you see that being, or is it kind of
Yeah, certainly.
either one?
Yeah, it is being increasingly prescribed. We look, for example, at spending on cannabis by Veterans Affairs Canada, which went from something like, I can't remember, but $80,000 a year to up to $80 million over the period of about 10 years. So it is increasingly being prescribed for PTSD. What I would say is that the evidence is not there yet. We certainly know that people use it what's called off-label, and what that means is that we haven't had the proper research yet to establish whether or not that drug or that treatment works for PTSD, but it continues to be prescribed off-label for PTSD. I think the rigorous research does need to be done. Where the research is very strong is that cannabis does certainly help to control chronic pain, and there's very, very strong research that supports that. I would not be surprised if the PTSD research also looked like that, but I don't know. That's only a hypothesis, and that work does need to be done. I don't know if Andrew, if you had anything to add to that.
Yeah, I would just add to that as well that more work needs to be done, particularly in dosage as well, because we know at very high doses it can actually be anxiety provoking and not anxiolytic. So yeah, I think the rigorous testing does need to be done, and like Margaret said, is showing promising off-label use, but yeah, that's kind of some future work that we need to do, particularly in PTSD.
Absolutely.
So Andrew, with regards to neurofeedback, you've interestingly done neurofeedback with fMRI with a single session, and you've also done neurofeedback over 20 sessions with EEG. So I imagine, and what I've heard from people that have experienced neurofeedback, is that it's sometimes very challenging in the beginning, and it's difficult to use this interface to control your own brain activation in specific areas. But after 20 sessions of neurofeedback, generally are people saying that they're finding the knack, they can keep within the thermometer, within that threshold of interest, or is it they never really get the key and it's just something that's more implicitly learned as opposed to explicitly strategized?
So I think especially with the 20 sessions of EEG neurofeedback, people really feel like they can gain control over that signal. I think this is in contrast to maybe the fMRI neurofeedback that we've done in just one single session. There's a lot of, and this kind of speaks to the guilt and the shame associated with PTSD, but for example, when we bring in participants, often they say, I wasn't able to control the signal, I'm kind of messing up your study, for example, and they take a lot of personal accountability and they're quite hard on themselves actually. But when we analyze their data actually offline, we see that they're able to control their brain area. So I think there definitely is a difference between the perceived ability to regulate versus the objective downregulation of certain areas. But also speaking to that as well, I think that for EEG neurofeedback, it is easier for participants to gain control over the signal. And that may be for a number of reasons. One could be that EEG neurofeedback is arguably a more therapeutic environment. So for example, individuals are in a room with just a clinician and they're just sitting in a comfy chair with this electrode cap on, versus an MRI scanner, which is very, very tight. Often people are claustrophobic there. You can't move your face at all. And you often have a team, because it takes a team of researchers to acquire these neuroimaging data. So there's almost like an audience watching you, essentially. So that can be very anxiety provoking, very uncomfortable. The scanner's really loud. It sounds like a machine gun going off around you, which is provoking, especially for our military PTSD patients. So it's hard to compare the two, but yeah, people definitely are reporting that they can get control over their signal.
That's great. That's great. So getting some more questions, and I'll try to combine two here with Paul and Joanna. So Joanna touched on the comorbidity issue, which is a huge issue with the diagnostic and statistical manuals that we use, right? Is that oftentimes somebody's coming and they're not just presenting with PTSD. They might have PTSD, they might have chronic pain, and they often also have depressive or general anxiety as well. So Margaret, as a clinician, when somebody's coming with multiple different comorbidities, is there a way that you target one first, or is it kind of just a more holistic approach, integrative approach, and through clinical therapy we move through these together as opposed to just tackling PTSD or just tackling depressive symptomatologies?
Yeah, that's a great question. I think I would say that the answer to that is not entirely known at the moment. And I'll give an example where often individuals who have a history of substance abuse and PTSD, when they go for treatment for alcoholism or drug abuse, it's that alcohol or drug is removed, often the trauma comes to the surface more so than even before. So maybe the case that, for example, if someone has experienced a sexual assault in childhood and they're being treated for alcohol abuse, the alcohol has been one of the coping mechanisms around that trauma. And as that's removed, the trauma can actually become much more distressing for the individual. In my opinion, and I'm not going to give this opinion, is, it's not, I don't have evidence for this opinion yet. I think there will be. I think those two need to be treated together, right? We don't want to put a person in a situation where we've unmasked, in a sense, the trauma and we're not providing concurrent treatment for it. I think that's really important. In cases where someone has depression and PTSD, what we would probably do there, what most clinicians do, is they target the most distressing mental health problem. So if the person is finding their PTSD to be more distressing than the depression, we would probably start there. That said, there's a lot of overlap between PTSD and depression. Many of the symptoms actually overlap with one another. So often if you're targeting quote unquote PTSD, you're going to get gains, you're very likely to get gains in depression as well.
And there's the added, so I was just listening to you about the substance abuse comorbidity with PTSD. Then you potentially sometimes you'll have the added wrinkle in therapy where we know that the social support system is one of the most strongest protective factors towards not developing PTSD or having success through PTSD related clinical therapy. But oftentimes you're probably seeing patients where their only support system might be among users, where using is one of the things that they need to not get rid of. Is that, you see that often, or is that another barrier to care in some respects?
Yeah, it's absolutely a barrier to care. One thing that we try to establish, I'm involved in inpatient treatment for PTSD, is to establish a sense of community on the unit. So really helping people to form strong social bonds and strong social connections that often have been lost through PTSD. When I used to do individual therapy, one of the hardest things that I found to move in people was, picking up the phone and calling a relative, picking up the phone and calling a friend. It's very difficult to describe how hard that is for some people to do that. And I think that really treatment needs to focus not just on things like memory for PTSD, but how do I help you to reconnect with your social world? How do I help you to reach out to your child who's estranged from you? How do I help you with that part of your social life? And therapy, in my view, should really target that. One thing that I do think, though, from the depression literature is that, we often do have a sense of dread around doing something like, for example, going out for dinner, to see friends, making a phone call, scheduling a Zoom call. It can just feel completely overwhelming. You might feel exhausted. You might feel like you can't do that. But people do find once they're in the moment doing it, on average, they do feel better at the time that they're doing it. There's also a real misperception. People think, for example, when they're off on workers' disability, that if they have depression and they're seen to be outside with their friends or they're seen to be, socializing, that's going to indicate they're no longer depressed. In fact, that is one of the most effective ways of helping people to overcome their depression is, again, giving them that support, getting them out in the world around them, doing activities, spending time with people, going for a horseback ride, going for a walk with your dog, all those things that can help to support you are actually, it's not a time where your insurer would be judging you for that. In fact, they would be probably quite happy that you're doing that because it is a way of fostering your recovery.
Yeah, so I'm here with Bob, and we were discussing before we started this PowerPoint presentations, which are also great, that during the SARS outbreak, we saw an influx of PTSD following the SARS outbreak, and Bob posed the question of whether we think that we'll also see that during COVID-19, which I suspect is a resounding yes. We're going to see an influx of PTSD cases, and I think a lot of that's going to come from these fractured or fragmented social support systems, right? We're having a difficulty connecting with one another. We can't go and do the things we would normally do, and engaging with friends, maybe via dinner or drinks, however it is. And then also you have that isolation that's associated with it. So I'm just gonna maybe close on this note and I'll first start with Andrew. During COVID-19, what's been the most difficult thing to adjust for, either experimentally or I don't think you do much clinical work, but experimentally, how is it kind of, I know you're actually in quarantine right now, so I'm assuming that's been a little bit of frustration there, but what's been the hardest thing to adjust for, to adapt to these turbulent and changing times?
For me personally, or for kind of our research group, or?
I guess we'll go personally.
Personally, I would say just your entire routine, everything. For example, I think I was talking with Margaret about this the other day, is that for me, the way I deal with stress is exercise always. And that really, especially if I find I'm extremely stressed and I feel I can't think clearly, I know I need to go to the gym, go on a run, something like that. And for me, not having that outlet was really difficult, I found. Extremely difficult, and also not having the work-life separation in the same way as well. You just kind of feel like you're tied to your computer all the time, and not having that separation. So I would say probably not having those healthy coping mechanisms for stress, like seeing your friends, seeing your family, especially too, because I was in Vienna up until I was living there doing a postdoc up until a couple of weeks ago. That was very turbulent as well, in terms of seeing my family, seeing my friends, and kind of dealing with that. Margaret, what do you think? What about for you?
For me, I would say absolutely with some separation from friends and family. That's a hugely important part of my life, and I found that very difficult. The other thing I would say is that I actually did experience COVID-19 related anxiety about returning to the hospital, because our department sits in the hospital of St. Joseph's Healthcare Hamilton. And I found it very difficult to go back to the hospital after having been away for, I think, about 3 months, because I did have that anxiety about, touching things, being exposed to potentially to the virus. But what I realized when I went back is that I had a lot more control than I thought. So for example, by hand washing, mask wearing, being very careful, using things that are shared like a microwave or a fridge, that you really are able to have more control than you think you did. But I had a lot of anxiety about going back. And I would say, yeah, absolutely. And I think part of that probably relates to my past history of trauma as well.
Yeah, and that's interesting. I think that's probably a piece that's often lost. So when we think about like the difficulties of administering therapy right now, I'm assuming, Margaret, you're doing a lot of virtual therapy, and I'm sure that comes with a lot of challenges for the patient or the client. But then you're also experiencing your own COVID-related symptoms. So everything is just a little bit more turbulent, a little bit more fragmented. And yeah, I think we're all feeling that to some effect or the other. So I'll just kind of wind down this question. Oh, Margaret, do you want to say something?
Yeah, if I could say something on that point, Brady, because I think that's a really important point, is that often, and I know there are healthcare workers in the audience, I think that people think of healthcare workers as being superheroes or superhuman, but healthcare workers have the same vulnerabilities, be that mental health, physical health, family stresses as everyone else. And so I think it's really important to recognize that, people who are coming to work on the front lines, first responders, people who are working in the grocery stores, essential services right now, they come with the same vulnerabilities as everybody else. And we really do need to pay attention and provide supports for those individuals.
Thank you. So I'm just going to close this down. Thank you both for the presentations. They were awesome. This is our first time working with Bob, obviously trying to do this webinar platform, and went, I think, quite well. I'm just going to close with Bob. Turn the mic to him if you have anything to say.
Yeah, doctors, Margaret, Andrew, thank you very much. Braden,
Thank you, Bob.
you as well. Good job. It is a first one, so we're going to look forward to some of the feedback, see where we can get better or in one way or another. But I want to thank you a lot for taking the time to do this.